We are here today to celebrate our annual Beals Lectureship in honor of Dr. Rodney Beals. And I just did want to say a few words about Dr. Beals and a little bit of his great and eminent history. He was a former resident here at OHSU. At the time of his retirement, he notes that he had met every resident who'd ever been here because he was sort of in the midpoint where the elderly faculty in front of him, he had still known them, and then he had worked here for so long that he had had the fine opportunity to meet everyone. And I think we've got some really wonderful alumni that have shown up today. Thank you for coming, all of you, and that's a testament to Dr. Beals. As I was thinking about the way we have this day structured, it's also a day to honor our 5 chief residents who are graduating, and they have some really great research projects to present. I'm sure Dr. Beals would have been proud of those projects. I went and took a look at some of Dr. Beals' CV and some of the papers he published, and you pretty quickly start to realize that Dr. Beals probably would have been working with some of you on these projects. You know, as I look at his papers, we've got osteoarthritis of the costovertebral joints with Rafe Sales, malrotation of locked tibia intramedullary nailing with Kevin Kahn, treatment of post-traumatic AVN of the femoral head with Rick Rubenstein, former residents, total hip arthroplasty in patients with Down syndrome, Mike Kioshos. Dr. Tower is going to talk about some work with total hip replacement, and so Dr. Beals and Dr. Tower wrote on fracture of the femur after hip replacement, the Oregon experience. Junior residents, you remember doing lots of saline arthrograms, saline load tests for penetration of periarticular lacerations with Greg Irvin. And one of my favorite papers, Fractures of the Tibial Plafond with Dan Ovadia. That's one of the probably 5 seminal papers on pilon fractures, and it was written in sort of classic Dr. Beals style. He went around and talked to all the orthopedists in Oregon and kind of said to himself, I know I've got some problems with these fractures. Went and collected everyone's cases from around the city and a little bit around the state, and pulled together 145 pilon fractures. This is a really large case series, and developed a fracture classification, and that's a meaningful paper to me, and it goes all the way back to femoral metastases and fractures from breast cancer with Bill Snell. So you see, he was working all over the body. He had a style where he just sort of paid attention to his patients, and when he started to notice themes coming through, he would collect patients, put together the research, and write it up for the benefit of all of us to learn. And that is in sort of a true honor of Dr. Beals. So thank you all for coming to honor him today. Our visiting speaker this year is Amy Ladd. I hope she had a really wonderful day yesterday with some of our, starting out with our entire residents. We had a really phenomenal cadaver lab working on upper extremity anatomy and tendon transfers yesterday, and then we had a chance to meet with some faculty. She spent some time with our chief residents and some of our PGY4s as well. Dr. Ladd is from Stanford, and she's been the vice chair and assistant dean for the Stanford School of Medicine. She's got a lot of expertise in advising, in working with faculty, and working with the department. And fortunately, she's going to share some of her great advice and lessons learned about hand and thumb surgery. And I'm particularly interested in her lecture on cartoons for some of the deficiencies in the hand, because that appeals to maybe my small orthopedic trauma brain. So thank you. So we'll get started. Dr. Ladd, please come forward, and we'll get started with her first lecture. And thank you so much for coming.
Thank you, Darren. Good morning, everyone. I'm really honored to be here, and every time I come to the Northwest, I feel like it's home, even though I grew up in upstate New York, but spent some time in Seattle in various parts of my life, and it always is just wonderful flying into the Northwest, particularly when you can see the Cascades and these gorgeous mountains. I had great fun yesterday, and thank you for letting me be a part of your day and your weekend. I am going to talk about thumbs, and I know that's a reason for your eyes to glaze over, but hopefully I'll bring it into some of the rest of the body. Some of my disclosures: I do work and live on the Stanford campus. Please come visit. The satellite dish that you see above is this, they call it a foothill preserve, or the dish area, and that's where I love to do my thinking, particularly on Sunday mornings, and that's it at sunset. We have an outpatient center about 7 miles up the road in Redwood City, which is where I see most of my adults and do most of my surgery. And the objectives today are to look at what are some of the normal features of the anatomy and pathophysiology of the base of the thumb, and how I look and we look for other joints to get ideas about how this troublesome joint works. But first, I really enjoyed the tribute to Dr. Beals, whom I did not know, but certainly knew of, and you know his accolades and his trials and tribulations to build up a great department, and what eventually became a great department under the directorship now of Dr. Yu. And I love this. In his obituary, there was this tribute to, it sounds very much like the man that Dr. Fries described, that his collaborator, Dr. Hecht, was a pediatrician, and in this obituary it said, their meeting was the consequence of an enduring academic challenge, scarce lab space. And something definitely we know in academics and other things, and from challenges come opportunities, and he certainly thrived on those. And then the Beals syndrome I had to look up because I was thinking it's somewhere between Ehlers-Danlos and arthrogryposis, and indeed it's, I guess, kind of like marfanoid with a genetic factor that he and Dr. Hecht identified like 50 years ago, 40 years ago, so crazy when we think about it. So, and I think my hosts here, Ellen Rainey, I've known the longest actually, and Rob Orfali I've had the pleasure of getting to know through the Academy Board of Directors. Please know that his even-handed intelligence is a great attribute to our academy. Dr. Yu, thank you very much. We shared some stories about the Cleveland, Rochester, Syracuse era. And Dr. Fries, wonderful program, and look forward to hearing and seeing you in the future. And I get to see you next week in Boston. And then Jackie Brady, what a wonderful simulation lab you're getting going, and really thrilled to see that. Thank you so much for setting that up yesterday, and look forward to more of the great projects that come out of your lab. Okay, then of course, it had a great time with the Chiefs yesterday. So Ben, Derek, Dayton, Carly, and Hannah, we had fun on our brew barge. And it's amazing that you can be pedaling sort of fast and be slower than any kayak. But had a nice view of Ross Island. Okay, starting out, well, I'm going to talk about 3 attributes of the thumb that perhaps informs how you think of other parts of the body. The thumb is unique. There is no doubt about it. And some of its design drives its function and vice versa. So I actually love this painting. It's the 4 corners of the world, it's called, but the thumb is talking to all the other digits, the metaphoric digits of the parts of the world. And it is a unique digit, and yet there's much to learn from other ones. And just how we think about it in different languages. So in English, the word thumb comes from the Dutch for stout. In Spanish, pulgar, which is really interesting, it comes from the Latin, from powerful, but it's interesting that in Spanish the word for inch is pulgada, so thumbprint is critical to a way of thinking. We all know about the Roman vote for the Christians and the lions, or at least how we perceive it. I do not know how to pronounce this, and maybe, Dayton, are you Greek or is your wife Greek? Okay. So I would pronounce it Antakir, but my Dean Soteriano says, no, it's like, which I could, but I love the word, that which is opposite the fingers. So opposition is not always, confrontation, it's actually balance and counterbalance, so kind of an interesting use. And the thumb affords us this great accomplishment and possibility, the precision, the grasp, all the things that are quintessentially human and arguably why we rule the earth, if you are truly kind of chauvinistic about how thumbs work. But it is a paradox. It is this joint that you must have a wide grasp to get something, but when it's there, it has to be stable. And so therein probably lies the conundrum that it has to be stable and mobile at the same time, and arguably that's how it wears out. So I'm going to walk through kind of three major threads, and first I want to talk about my collaborators at Brown University. We have an NIH grant looking at the mechanics or the kinematics of the base of the CMC joint in functional tasks, and we have taken individuals who have no evidence of arthritis, no symptoms, and compared those to individuals with early arthritis and followed them over a 6-year period. And we're just in year 6 now, so can begin to talk about what we're finding. So I'll play this one again, but take a look at the thumb metacarpal as it rides over the trapezium, just to get some ideas of that this is more complex than a ball and socket or flexion extension. But the things that we are looking at are, again, these quintessential human things, so grasping a jar or a water bottle, opening a jar, and then pinching, so precision pinch. And we have looked at these with CT scans and then segmented them. But you get the sense in coming into, from a grasp, that the thumb metacarpal flexes, and then when it's secure, it rotates. And that's been one of our findings. I'm kind of telling you my talk, but if you think about that, you realize it's not just a simple joint at a small level. And in fact, when you look at thumbs with no arthritis, just doing these tasks, there's different load or actually contact of the metacarpal on the trapezium. And it makes sense. If it's an eccentric shaped joint, it's not going to have contact like a ball and socket. And again, perhaps this is correlated to how it wears out. So we found, again, in the normal individuals, that there is a coupling motion in that flexion and abduction. So flexion of the thumb and abduction move together, whereas adduction and extension move together. So multiplanar in a sense of you take kind of a hip and a knee and you put them together and you get similar discussions. Well, my girl team, my foreign team from Sweden and Germany, we're looking at proprioception, so actually looking at the ligaments. So whereas anatomy and configuration is important, so is proprioception. Proprioception is complex. It's what goes on in the brain and the vestibular and visual and all those things that we as orthopedic surgeons don't think about that much. But then the reflex loop of mechanoreceptors, nerve endings, and even the tendon. There's Golgi tendon bodies. We've looked specifically at the CMC joint for mechanoreceptors and nerve endings and found some interesting things. First of all, that the ligaments on the back of the thumb, so this is a left thumb looking from the back side. Here's your abductor pollicis longus. The dorsal ligaments are quite stout and robust cellularly. They are replete with mechanoreceptors. Arthroscopically, they look sort of like an ACL. And on the other side, on the volar side, it's quite thin and attenuated. The anterior oblique ligament, for some of the older folks in the room, you were probably taught that the anterior oblique ligament was the primary stabilizer of the CMC joint, but in fact it's not. And multiple folks, including our own lab, have looked at this extensively, and it's probably just a thin capsular structure, but the robust support is actually afforded by the thenar muscles. and the muscle right intimal to the CMC joint is the opponens. And similar to the shoulder, the stabilizing muscles are pretty critical to stability of the joint. And furthermore, the ligaments of the volar complex are really acellular and irregular and do not have mechanoreceptors that we classically think of. Doing some modeling, so taking the anatomy and putting it together with a ligament structure, it looks like if you do just finite element analysis, there is no stability to the volar complex on purely ligaments, and again supports the concept that muscles may be critical to the stability. Okay, so I do a lot of CMC arthroplasties. I do like 2 a week, and that's a big deal. It's the most common procedure for arthritis on the hand is the base of the thumb. And we still haven't figured it out, so you know, what's missing? And that's part of what we're looking at. Just gonna go through some current beliefs, and I love this painting, Thomas Aikens, who's most famous for the Gross Clinic that's at Jefferson. So if you guys are going there, you should see it. It's a painting of the Dr. Gross, and he's dissecting. But he did a fair amount of, he really studied anatomy well. And here's Mrs. Mary Arthur with her base of thumb arthritis crocheting. And, we think of this as sort of little old lady disease. Well, the average age of this surgery is actually younger than me, so I'm hoping that we can change the paradigm that it's not a little old lady disease, and in fact, men get it too. Surgeons are probably prone to it. But it would be better if we could even prevent this. So that's the ultimate goal. Genetics plays a huge part. That's not where my emphasis is. There are other people looking at it. I think this is going to be a conundrum to resolve with things of accompanying hip and knee arthritis. What is the correlation? What are the populations susceptible to it? But there's no doubt who your parents are plays a huge role. The older we get, the more likely you're going to get it. And in fact, a study on distal radius fractures looking at incidental arthritis of CMC joints that David Ring and folks did at Mass General showed that the older you get, the more likely you get it, like 100% if you are for a woman in your 80s and men if you're a little bit older. So it's not that you're not going to get it if you live long enough. Is it symptomatic and does it need treating? We tend to think of it as postmenopausal, but again, men about 10 years later tend to have the preponderance. We think what we do has a role, maybe, not as much as we thought, and that's what we're finding. We think of laxity. Individuals with Ehlers-Danlos are definitely susceptible to it, but it turns out that laxity is normal for this joint. In our normal population of our NIH study, about 30% of normals have significant subluxation at the CMC joint. And does that mean they're going to get it? I don't know. We'd have to follow them for 20, 30 years. But how does this beautiful, pristine saddle-type joint end up like this one? This is the one we operated on, or I guess I operated on yesterday, was very similar to this complete reversal of the convexity in the volar dorsal plane, and probably had an x-ray that looks something like this, just total obliteration of the joint space, these kind of volcanic eruptions on the ulnar and radial recesses, and compensatory hyperextension at the MP joint. Well, currently, let's see, we think of arthritis in radiographic means, and it's like we were talking last night about periprosthetic fractures, and maybe x-rays aren't good enough, and I think our x-rays aren't good enough to really ascertain what disease is. We talk about progressive disease in using the Kellgren-Lawrence scale, which is used pretty much throughout the body, but this doesn't really tell the full story. And I contend that a lot of it is in what we don't talk about. What is the relationship and the size and the morphology and the rotation of these other joints between the scaphoid, the trapezoid, and the second metacarpal? Well, so in the dissection yesterday, I mentioned I have hundreds of floaters of trapezia in my office. Actually, they're now in somewhere else because of IRBs and all that other stuff. But we've identified 3 patterns of wear. And I do want to show you I mentioned we're up to 6 years with our NIH study. And what we have found that between men and women, the shape is the same once you orient for size. Weakness in pinch and grasp precedes X-ray changes. So because we followed them out and we're using CT scans, the CT scans are more specific than the X-rays, you might think. And this is actually what we hear in the clinic all the time. People will say, well, it's weak, or it hurts a little, but it's weak. I can't do those jars. This is me, I can't tear open those packages from Trader Joe's with the fruit around it. I can't open a Q-tip thing in my hotel, you know, and I use my teeth, probably. I'm not the only one who does that. And in women, joint space narrowing occurs before radiographic disease. That sort of makes sense. Women are smaller and the cartilage is less thick, and so you would expect to see something. But it's kind of neat because we haven't been able to really quantify these before. But it turns out we find no difference between men and women in the normal state and in the progression of arthritis, which is not, I think, what we're taught or what we have presumed. And that's just showing that pinch decreases as radiographic changes do. And so here's some 3-year data, and again, I said we've collected up to 6 years. We just haven't analyzed it all. But indeed, the shape changes. They become wider in the radial ulnar plane as you look at it in profile, and relatively speaking, narrower in the volar dorsal plane. And similarly, in the metacarpal, there are slight reciprocal changes to this. So that's pretty exciting. So we're actually seeing what progression is, as opposed to advanced arthritis when we take the floaters out and look at them. And so we found with those that have bad disease, they're symptomatic, that people wear their joints out in one of 3 ways. One where they keep the saddle. This is a micro CT where you see in the volar dorsal plane retention of that convexity. So that's the retained saddle. They totally obliterate it and reverse it. So that's that dish pattern like we saw yesterday. Or in some, there's this neo-facet, if you will, on the volar aspect. And because I like to ski and the medical student working with me at the time likes to ski, we called it a cirque. For those of you with glacier mountains, that kind of lip on the top. And furthermore, when we go back and look at mechanoreceptors, they're not anything like in the normal state. They're crazy. They're we don't know what most of them are. They seem to be vascular in nature. And maybe this suggests that there is a mechanism going on that is informed by the environment. The proprioceptive fibers may play a role in this degeneration. And furthermore, in looking at the synovium is probably more information that the synovitis score correlates really well to the pain score, but does not correlate well to X-ray. And I think we're finding that. I think there's some hip studies that are showing something similar to that, and that will be a thread for particularly the young folk in the audience to think about. Well, I do think that the answers lie all around the thumb to figuring out this arthritis and prevent it, and this concept of joint homeostasis. It's rheumatologists have talked about it for years, but it's becoming part of our vocabulary, that you have all these things from the muscles, tendons, you know, the bursa, synovium, the cartilage, the bone itself, but probably all of these play a role in non-traumatic idiopathic osteoarthritis. So keep that in mind, and I think you'll begin to see increasingly from both the orthopedic and the rheumatologic literature about contributors to that. And as I mentioned previously, I think, you know, here's a clean X-ray. Here's the second metacarpal trapezial facet, the trapezoid trapezial facet, scaphoid trapezial facet, and of course the one we talk about a lot with the metacarpal and trapezium. But look, this totally clean joint on this side compared to the opposite side where the pommel of the saddle is sticking way up here. And so this is, although not much in the way of ST arthritis, there's definite arthritis here, and that probably has a lot to do with how well they do and can we prevent that? Can we do something? Is there something about this x-ray or this individual's hand that we can stop so in 5 years it doesn't become that? So that's the challenge that we have and hope to work for the latter part of my career on. Ernie Kaplan is from Case Western, and he's a great scientist. He's the one who really got us on the stem cell thing about 15 years ago. And he talks about some of the markers and the mesenchymal stem cells that contribute potentially to this pathway. I have no idea how to explain this, but it's a pretty cartoon. So in a segue from my talk this afternoon. So, and then just pulling out the kinematics of the upper extremity, we are looking at ways that how we compensate, just like in a child with cerebral palsy, the same type of marker analysis. We can look at someone doing that jar opening task. Someone with arthritis can't open that first web space, and it takes longer to do and less efficiently. This is a normal kind of curve of jar opening, very much like a CP child reaching and grasping. Their entire upper extremity is contracted, so they do it inefficiently because of spasticity, and they don't have that environment open. So ideally, these kind of tools will help us with training and understanding of how much compensation we do because of arthritis at the thumb or arthritis in other joints. So, and looking to other joints, so here's that saddle, it's eccentric, and so rather than being a pure flexion, extension, abduction, adduction, because of this eccentricity on the radial aspect, you know there has to be a rotational component. And furthermore, what I mentioned, showing those osteophytes, it's not all that different from a glenoid that undergoes significant dysplasia. And that eccentricity is similar to the eccentric condyles of the knee, where you have the screw home mechanism. You rotate this along, it's going to kind of go in a curve, and that's exactly what happens at the end of that pinch component. And then that bicondylar joint, which we see either in the shoulder or the natural state of the knee, is a bit like that cirque pattern, that kind of dip at the top. Whereas I think it's the volar positioning of the metacarpal and the trapezium, we don't know, and would like to figure that out. Again, like the double-crescent glenoid. And then it turns out, are there any foot and ankle surgeons here? So the first tarsal metatarsal joint, obviously being the homologue in the foot, has different shapes, and potentially that's somewhere to examine as well as looking at that thread. The shapes are associated with hallux valgus, metatarsus adductus, and hallux rigidus. And those are opportunities for sharing knowledge with our colleagues to understand that. And when all else fails, evolution simplifies, and you get a ball and socket joint, kind of like that dish, which is what obviously the hip joint is, and perhaps that's where we're headed evolutionarily. Well, I do think that neuromuscular control is a lot of the money, and I think that would be if I could do anything for the next 10 years, that would be the focus. And looking at instability and imbalance, which is perhaps not all that different than acetabular femoral impingement or shoulder instability and other things that we see in the musculoskeletal system, that imbalance probably plays more of a role than we give it. So it is a puzzle. It's a complex joint, and there are opposing demands of stability and mobility, and where may occur through different mechanisms and different etiologies that we're picking away at. Think of this concept of joint homeostasis as you go forward in your careers as residents and young attendings. So far, we can't really find differences between men and women as it relates to their anatomy, physiology, and their mechanics. So what's next? So would love to reduce all this research into something pretty simple. We've described an index just looking at the Roberts view, and this correlates. So the more arthritic you get, the more these radial and ulnar extensions occur. And so here's such a trapezium taken out. You get that big pommel up here. And it correlates extremely well to how much eburnation or lack of cartilage there is on the joint. Can we use this as a predictor for intervention? So for instance, someone who wears out like this with basically the same saddle shape yet has some increase in their distance, is this a person who should get an extension osteotomy? Is this a person down the road, if we have a better implant, that should get an implant? And right now, we're sort of stuck in the 1950s, that we take out the trapezium. We do whatever you want. They all do, quote unquote, well, because they have good pain relief. But quite honestly, Roman vote down, this is kind of dumb, Why are we here? And so my colleagues and I are working at it, and I hope by the time I retire, we have something to offer. Well, teleology is the purpose and design informs its function, and so that's kind of where my head is at, and takes a lot of folks from all different disciplines to make this happen, and so working with a lot of them. So again, here's my world and my cheesy analogy. The Bay Area is like the right thumb. You look from the back. We have warriors. We like our warriors. I know you like your trailblazers, but we like our warriors. And so this is, again, cheesiness. The base of the thumb is somewhere around the Stanford area, right there. But it really is beyond, looking to all the corners of the world, all my collaborators around the world, and collaborators of the orthopedic world, as is you in this room, and look forward to hopefully working with some of you in the future, and please come visit. And here are the many folks that have had some aspect of this work. And Dick Burton, you guys heard me talk about him. There's always a snake in the grass. That's him. And I told you that in his office, big bald eagle, big hook nose. I am smiling. That's my guy. I'm very good friends with him to this day. He taught me so much of the Burton Pellegrini procedure. Certainly you know him. Barry Simmons, my fellowship director. Rod Hentz, who hired me at Stanford. Bob Chase, who also hired me at Stanford. Bill Littler was his mentor. And the many institutions and students and residents, and especially our hand therapists, because they're the ones that make our surgery even better. So thank you for your attention. Dayton.
Thank you for the talk. That was excellent. You talked to us a little bit yesterday about your surgical management of arthritis. My question is, when do you find yourself doing anything with trapezoid, and if so, does it correlate with their clinical or radiographic findings are preoperatively?
Great. So Dayton asked.
Can I ask you to repeat the question? Just in the microphone, sorry.
Got it. Okay. Okay. So Dayton asked a question about involvement of the trapezoid at surgical finding, or just in general?
Yeah, radiographic, and then what you see during surgery and how you manage that.
Okay, so Dayton asked a question about what to do with the trapezoid if you've seen it ahead of time on X-ray and or at the time of surgery. And maybe I'll go back to an X-ray just so we can talk through it. I can figure this out. Oh, probably easier just to do it this way. There's one. Okay. So this one's kind of interesting because I now look at it and I know what's going on here. There is definite scaphoid trapezial arthritis, and where you may say, maybe not here, but I know that this has disease because there's tons of synovitis in here. And this is truly pan-trapezial arthritis. And I don't know what I did here, but I suspect what I did is I did the procedure that I showed you yesterday, a suspension of the second metacarpal to the first metacarpal with a suture sling. And probably on this one, I took off the undersurface of the trapezoid. And because this is true pan-trapezial arthritis, or I think of circumferential. Now, the one on the left here was essentially normal. Let's pretend for a minute that there were arthritis here, and I thought this was a pretty clean joint radiographically. And I got into surgery, this actually happened on Monday, and I actually found arthritis at the scaphoid and the trapezoid, but there were no symptoms, and this to me looked like a clean joint. I left it. I didn't think that was part of the disease process, whereas this is the entire complex. Yeah, Jackie. The fine motor one? Okay. Okay. So for the CT study, so it's actually stop-start kinematics. It's not big motion analysis with the markerless tracking like the upper limb, like the CP type lab. So we are looking at, so if this were a jar, there's a load cell on the jar, and grip is around it. So we do a CT scan at rest, and then at 80% effort. And so that's kind of the start-stop. And so, yes, I'm doing cartooning stuff with that's the theme of the day. With that motion, we just linked it together. So, okay, Dr. Yu.
I have a N of one patient, that's me. I used to have a great pride on my thumb pinna muscles. That's the only place I really have muscle. I used to rip apple in half and show people like how's going. Well, turns out I have CMC Arthritis in the left hand, and I can no longer rip an apple like that. But I tried a lot of things, like a thumb spica and all these things. None of that actually worked for me. And I thought about it for a very long time, and I decided to use kinesio tape. I know it's crazy. But what I decided to do was it was subluxing, so I put one across the base to keep it in, and then use the 3 strips. And I do that on the weekend a lot, and I can function really well. Do you think I'm crazy?
How do I paraphrase that? So, yes, repeat the question. So Adam, I'm not going there. So no, so Dr. Yu asked a question. So he personally has had base of thumb arthritis more recently because he used to be the heroic orthopedic surgeon ripping an apple in half. And that was problem number one. But talking about how kinesio tape has really helped you, and I think that's fabulous. You sort of played into my talk. So there's a physical therapist at Minnesota by the name of Virginia O'Brien, and she and collaborators at the University of Minnesota have shown kinematically that the first dorsal interosseous and the opponens, which is the deep, deep one, work in concert to keep that joint concentric. And they've shown it biomechanically with a cadaver, and she's supported that with rehabilitation exercises specific to it, which is the protocol we use. And I think what you are doing is giving you that proprioceptive feedback with kinesio tape to keep that joint centered.
And I was using the joint.
Uh-huh.
Which I found that immobilizing it just started to hurt.
Yeah. Yeah. And there's another brace which you might want. It's called a push brace, which is the soft gray plastic one, which does that. It allows you to move, but it kind of keeps you in that position. I know surgeons who have some in the OR that they sterilize somehow and figure out. But there's a lot to it, and again, it's why our therapists are so critical, both before and after. I think rehab exercises before surgery informs the outcome. Steve.
Is this, in your initial introduction about the proprioception and the neurologic feedback, do you kind of think of this as Charcot arthropathy as being manifestations?
Great question. First of all, let me give a shout out to Dr. Steve Tower, who he and I are alumni of Dartmouth College, and I've met several times in Alaska, and one of your illustrious alums. Dr. Tower asked the question about, is advanced arthritis like a Charcot joint? Absolutely, and I think, you know, there's even investigations of how can you knock out nerve fibers to create a Charcot joint without doing the surgery. I mean, that sort of makes sense to me. I do think, and I also think individuals who have horrible arthritis who don't hurt have become Charcot. And can you get a Charcot that's functional and, you know, strong, you know, that you're creating a proprioception? But I do think so. Charcot, there's a foot study looking at Charcot mechanoreceptors, and they may be similar to the ones that we've seen on the arthritis ones. They're sort of also bizarre, not really in the categories that we know what they are yet. So.
If that's true, and I've probably read this and forgotten about it, is there a high correlation between dominant hand and
No.
incidence?
No, interestingly, so in my just kind of rough guess of population, so majority of people are right-handed. So just for statistics, if there's anybody left-handed and weird like me, 20% of boys are left-handed and 5% of girls are left-handed. And so you take that mix, so you've got about 11% of the population that's left-handed. But I do almost 50-50 left and right. And so why is the left hand more affected? You could argue you use your non-dominant hand as a stability hand, and maybe that's more forcefulness. I don't know, but we'll see.